All right. Well, thank you guys so much for having me here. It's an absolute great honor. And I'm Dr. David Rastall, and I've been told that I should tell you guys how I'd like to handle questions. And so what I'd like you to do, if it's all right, is put any questions you have in the chat, and I might enter do get a little cluster of questions as we go through intermittently. So if that sounds fantastic. What we're going to be talking about today is an intersection of how artificial intelligence and the actual structure of it impacts elder care. And one of my passions is that if everyone can just have a little bit more understanding of artificial intelligence, you don't need much, but then you can link that to your area of expertise, be that dementia, be that health safety, be that whatever it is, and really see how that little technological aspect interfaces with the complexities that you already know. I'm a neurologist who focuses in neurodegeneration, especially of the back of the brain, so cerebellar ataxia, Parkinson's disease, progressive supranuclear palsy, multiple systems atrophy, and that whole spectrum of disorders are typically what I see in clinic. And I'm the lead for AI innovation at the Armstrong Center, and I run the Max Lab, where we study how artificial intelligence functions in healthcare settings. Once again, thank you so much for allowing me to present to you. It's a real honor, and I think it's really critical to have some of this cross training between artificial intelligence and the world leaders in aging research. And so, really quickly about me and a little bit about AI in general. My undergrad degree was actually in artificial intelligence back when it was so uncool that you couldn't publish a paper with the term AI in it. You had to use some other terminology, whether it was a neural network or an evolutionary algorithm or something. But AI was considered a complete failure. And it was always my passion, but I thought, well, I better go off and become a doctor and get my PhD in cell and molecular biology because this AI thing nobody sees as a future but me. But I followed it all the way through its phases and through a whole bunch of recent innovations, as everyone's aware, all of a sudden it went from being something that was a bit of a novelty to being something that was phenomenally powerful and now to be something that's poised to take over a lot of fields and transform the world. And so, the term AI is a bit of a marketing term, or it's a bit of it creates some confusion. And so it's really important to understand that when we're talking about artificial intelligence, we're not talking about one thing. And so very frequently you'll see, oh, we're talking about, machine learning, neural networks, large language models, and like something might be called like, this is the safety that you need for machine learning and artificial intelligence. These are fundamentally different technologies, each of which have fundamentally different strengths and weaknesses. And understanding a tiny bit about how they function is really, really critical for ensuring the quality of elder care. And so we're mostly going to focus today on large language models, but I am just going to explain a little bit about neural networks to say how they're different, because large language models, the very first paper that introduced them was in 2017. And really the state of the art ones existed about 2 years ago. So they're so relatively new that nobody is an expert in them, including the people making them. So, what we're going to be talking about most of today is how large language models both give really cool opportunities for our older patients, but also introduce novel risks that our older patients might be even more susceptible to than other populations. Whoops. And so, there's basically pros and cons with LLMs and aging populations. One of the questions I always get asked is like, are old people even able to access or use these? No, they can't use them. Old people don't use new technologies. Well, because LLMs, the interface is either text or speech, they're very, very accessible relative to more complex technologies that require you to do more things. And many of my patients, all the way up at any age, are using large language models. And this will only become more and more true as they continue to permeate culture. So I think there's a lot of opportunities there because they're so accessible. However, on the flip side, there's several features of large language models, some of which have been intentionally engineered, that are huge patient safety hazards and the elderly patients might be particularly susceptible to. Some ones that we can talk about briefly are sycophancy and alignment faking, but the one I'm going to talk about doesn't even have a proper name yet, and the closest we have is something called steering. So I want to go over two real world case reports that kind of illustrate the potentials of this. So in this first case report, these are both real cases. There was a man who was talking to ChatGTP, and he wanted to remove table salt from his diet, a laudable goal for someone with high blood pressure. And it was a very long conversation he had with ChatGTP, and it ended up getting very technical. I want to take the table salt out, but I still want to taste the table salt. How do humans taste salt? Oh, well, you use the salt receptor. Oh, there's a salt receptor. How does that work? Well, the salt receptor works like this. What other ion on the periodic table might activate that salt receptor? Based on my analysis, I think that bromium salt would activate that salt receptor the same. All of those things technically true, but the patient ended up replacing table salt in their diet with bromium salt. And this is a disease that hasn't really been in the world since the 19th century, when bromium was more commonly used by humans, but they ended up developing bromism. Bromium toxicity. So this particular patient developed severe paranoia, which didn't help, confusion, hallucinations, and then psychosis. And fortunately, a relative saw them and they had a bromine rash all over themselves. And so they were taken to the hospital sort of against their will, where they were successfully diagnosed with bromism. But this is an example of a direct possible patient harm, because patients every day are asking large language models medical questions. Now, on the flip side here, there's this case report that's been published about a mother and a son. The son is the patient, and he was suffering chronic back pain and a number of other symptoms. And the mother felt he was being misdiagnosed, which, as we know, happens frequently to our patients. And frequently, they're the ones with the best intuition about that. As I, like every other doctor, never once has misdiagnosed a patient. So eventually she got frustrated with these strange symptoms and this low back pain, and she input all of his case into ChatGTP and asked a bunch of questions, and it correctly diagnosed him with tethered cord syndrome. And when she came back with that recommendation to her doctors, they got an MRI of his back, and they found that he did, in fact, have tethered cord syndrome. And so a good question that I don't believe anyone has a complete answer to is, why do some patients, when they're interacting with large language models, get phenomenally high quality medical information, and others get terrible medical information or even poisoned by the exact same model? This is something that's unique to artificial intelligence, because obviously this is the exact opposite of what we would expect from a human intelligence. If there's a doctor who typically gives fantastic advice to your patients, it's going to be your assumption that you send them another patient, they'll probably continue to give great advice. And this gets into a deeper area that I'm really passionate about. But it's my belief that the thing that's needed the most in the world right now is for all of the experts, especially in healthcare, to learn just a little bit about artificial intelligence and their actual inner workings. Because this allows, even that little bit of knowledge destroys that fragmented intelligence. What's happening right now is you have these companies that are full of like 20-year-old tech bros who are really steering everything. And then you have over here people with tons of expertise in aging populations, in system science and human factors in medicine. And there's really no one who has the knowledge of either side. And so even a tiny bit of understanding, like I'm about to show you, and I think all of a sudden lots of things are going to start making sense. So the first thing to understand about LLMs, because the companies do a very good job of trying to pretend the exact opposite, is that large language models only see text. They see text coming in at them, and then they output text. And you might think, no, they can see images, they can surf the web, no, they can't do any of those things. There's a tool that is between them and that thing that they then activate, and that it converts whatever it is into text, and then back from their text into the thing. So if you tell Gemini or ChatGPT right now, make me an image, like all the images in this presentation thus far, make me an image of a patient with bromism, it will make this image, but it did not actually make the image. It made a whole bunch of text that made a different tool make that image. So at their base, they're very simple things. It's literally text in, text out, text in, text out. But as opposed to convolutional networks and other traditional AI, they have infinite possible answers. And when people talk about like, ooh, generative AI, it's completely different. And you're like, what's the difference compared to any other AI? One of the big answers is that if you take a convolutional neural network that's trained to recognize lung cancer, it's going to look at a scan, whatever you trained it on, an X-ray or a CT, and it's going to say, that's cancer and that's not. The worst it's ever going to get is a wrong answer. It could say that something that is cancer isn't. It could say that something that isn't cancer is. That's the worst it can ever do. A large language model can do anything. There have been large language models that were talking to depressed teens and talked to them, according to court briefings, so allegedly, into encouraging them to do self-harm behaviors. And that's just not a risk of a convolutional neural network that looks at a lung scan. So when there's infinite possible answers, how does it choose and how do we make it choose what we want? And this is an open question that nobody has completely solved. All we've solved is a way to do it good enough. And so the way that large language models work is that they're trained on all human text. So everything that has ever been written by you and published, they have read. Everything that is in any textbook, they have read. Most of the internet, they have read. All of Reddit, message boards, emails, they've read it. And they then encode the meaning of those words in their learning space. And what do I mean by that? So if you look at the brain of a large language model, somewhere in there, there will be, and when I'm going to use word and token interchangeably in this talk, what really happens is that each large language model breaks down words into individual tokens. Sometimes, like the word man, certainly is almost always one token, but other words might become multiple tokens. It might take out a prefix like pre, from prefix, it would probably take out pre as one token and fix from the other. For the sake of this talk, I'm going to use the word in place of token just because it makes things clearer, but I'm actually talking about tokens. So inside the mind of the large language model, there is the word king and there is the word queen. And they exist in a space, which we can imagine as a three-dimensional space, but it's actually many, many dimensional. And so you can map the word king to the word queen. So it will know, oh, if you want to get from the word king to the word queen, you take this path down and to the right. And then when it sees the word man, it could think, what is the equivalent word that is as queen is to king, what word is to man? And by wandering down to the right, it might find the word woman. And that is how large language models encode meaning by reading many, many, many things. They put the words in this space where the spatial connection between the words encodes the meaning. Similarly, this is why large language models are really good at translating, is in languages like Romance languages that very frequently have one-to-one words. This is Latin over here, but the word for man and vir is going to be very similar. So the encoding from man to woman in English text is going to be very similar from the encoding from vir to femina in Latin text. And so, so they work really well when there's words with similar meanings. But here we get to the first problem. When I say king, there's many things I could mean. I could be talking about the king in a card game. I could be talking about the king in a chess set. And I could be talking about an actual king. And so when it learns the word king, it learns it in multiple ways. It will have an area of its brain, which is, I'm being metaphorical, of its encoding, that has encoded concepts around royalty as they appear within that lexicon that it's encoded. It will have one for chess and it will have one for card games. And we'll have a lot of others that you might not anticipate because you're not on some weird, message board where they use king as slang for something else. So when it encodes king in all these areas, it can then choose which one it is paying more attention to. And it does that by the prompt that it's been given. So if it sees the word king in the prompt, it might say, ooh, king is associated with all of these areas of my encoding. But which should I pay attention to? Well, I'll look at the other words in the prompt. So, so then if a prompt had the word king, rook, and castle all in it, it might say, oh, king and castle. Well, both of those are related to my royalty encoding. So maybe that's what they're talking about. Oh, but also they use the word rook, and both king, castle, and rook are all related to my chess encoding. So maybe that's what they're talking about. And so this is called attention. And what it means is that every layer of the LLM's mind takes one of those tokens and then activates a layer deeper of its mind that then activates a layer deeper of its mind, and so on and so forth until it generates its understanding and its answer. So here is the problem that hasn't really been thought of. AI, like I said, has encoded every single high quality source of medical information, like a medical textbook. But they've also encoded conspiracy theory message boards, excuse my typo there, conspiracy theory message boards and sources of intentional medical misinformation, like a website selling some kind of male enhancement powder. And both of those exist in their mind. So if a patient were to type in, I awoke today with acute homogenous hemianopia, what should I do? If it wouldn't be encoded as a single token, but the word homogenous would more likely steer the model, and the word acute would likely steer the model more towards where it encoded high quality medical information. Whereas if a patient used slang, I got up today and ain't seeing good, the word ain't probably doesn't appear anywhere within the medical lexicon. It's not anywhere in any paper published in PubMed. It's probably a slight exaggeration, but you get my point. So certain words will steer the model towards different areas of its encoding. And what we find in our research is that when that happens, and I tried to do this as a live demo, but the live was not working. So I'm just going to show you pictures of what the demo looks like. But when this was done, we have a system in our laboratory to do this live, and we can actually see what areas of the LLM's brain light up. And what we've done is we've taken a whole bunch of patient questions and we've imported them into this. So this is a particular patient who has a glucose 6-phosphate deficiency, but they refer to that colloquially as the numbers. So when I met them the first time, I said, what's your past medical history? And they said, well, I got the numbers, doc. And so that is the terminology that they use to refer to this. If they were interacting with a large language model, they might tell it the same thing. So what we have done is we've taken little question stems that a large language model might say, I have G6PD and I ate beans, I will develop. And we've done this with I should go to, et cetera. And what we see is that the model, as far as the next token it's going to generate as an answer to this, it says things like jaundice and hemolytic anemia. And those are all correct. If you have G6PD and you eat certain types of fava beans, you develop hemolytic anemia and jaundice. If you replace this patient-chosen word, so G6PD, the correct abbreviation for this disorder, with the numbers, then it says that you won't develop any of these things. And if you ask the model, I have G6PD and I ate beans, I don't feel well, I should go to, it will say the hospital, the emergency room, and places like that. If you say, I have the numbers and ate beans, I should go to, it will say sleep. This is an actual, again, I was hoping to do this live, but it's just not working today. But this is the actual tool that we have. And what it does is it takes what's called the embedding, which is the patient entered question. I have G6PD and I ate beans, I will develop. And then it shows every layer of the large language model's thoughts going deeper and deeper here. And you can actually trace out where it puts all this together, and it starts thinking about livers, and it starts thinking about blood disorders. And then it puts those together, and then it starts thinking about how beans could impact that. And then it comes to the correct conclusion of jaundice or hemolytic anemia. And you can see, and essentially it's a little cascade of its thoughts. And when you look at what those encodings are, they're scientific literature, published literature, and doctor notes. When you do this same thing, but use the patient word of the numbers, it goes to areas of its brain that encoded message boards and rap songs and all of these other things, and it never comes to that correct medical decision. The takeaway from this being, first off, that for our elder patients who might use slightly different terminology, the words that they're using, both when they're being recorded in the room by listening AI and when they're asking programs like ChatGPT about their medical questions, are going to be influenced by the dialect they have, the words they choose to use. Are they using an outdated phrase? Are they speaking in the African American vernacular? And that particular slang is not encoded in the part of the brain that contains the high quality medical information. The larger takeaway from this segment of the talk is that a tiny bit of understanding, even this level of understanding and how large language models work, probably instantly sparks a lot of ideas in your head of, oh yeah, I have patients that use this strange terminology to describe their diseases, or no patient would ever know the exact correct way to describe them. Part of what I do as a clinician at bedside is I coach them. No, no, no. You're like, so in my clinic, we see a lot of people who have dizziness from their posterior degeneration. But they'll use the word dizzy, and the first thing I have to do is figure out what they mean by that, because some of them mean that they have ataxia. They don't feel anything off at all. Their feet don't work in the correct way when they go to walk. Other ones do mean that they're dizzy, but they mean they're lightheaded, and still others mean that they might have vertigo. And so I have to parse all of that at bedside to figure out what they're meaning to ensure good communication. And then once I know what they're actually saying, I can activate the correct part of my medical encoding and get them what they need. So let me pause there and take any questions on this part, and then I'm going to talk about a second safety risk that exists in large language models. And both of these are risks and opportunities, because by the same token, you can use this to drive the model to overperform. So right now, let me pause and just take any questions that exist so far. I'm very sorry that it was derogatory to refer to elderly patients as old people. I apologize. What I mean is that patients above a certain age, whatever you define that age to be, have certain risks, both medically and culturally, and I appreciate that. And they are a very diverse group as well, and that should also be recognized. So I appreciate that. Thank you so much. Someone, and that was from Jin Poon. And if you'd like to explain further, feel free. And the next question is that this really resonates. The vernacular for diabetes I've heard is I have the sugar. Exactly, exactly, in African American communities. And so that's exactly what we're observing. I have the sugar. And sugar does not drive the large language model to think as accurately as if you say I have type 1 or type 2 diabetes. And so this is a huge patient safety risk, and it's one that's relatively easy to fix if you understand a small amount. But then this gets into increasing complexities, which, as Jin pointed out, I am not at all an expert in this, but what is the African American community? And once again, it's a very diverse group of different people with many different vernaculars. At the end of the day, what is the risk are the words that the patient uses. So that's how they should be defined as far as this particular problem. Is there technology that can mitigate this? Yeah. Really easily, actually, in our research, which hopefully this research will be out soon. You guys are seeing it a little bit before it's published. If you take if you give a sample of the way the patient's typing to a separate large language model and then say, this is the way that they talk, and then take the medical question they ask and say, turn this into a very standard medical way to ask this question, according to medical literature, it instantly improves it drastically. Because remember, this is the question people always ask. They say, okay, so there's this area of medical literature and there's this area of slang and weird stuff over here. So why don't you just train the model on medical literature and then you've solved the problem? Well, because patients don't talk in medical literature. No patient has ever said they have homogeneous hemianopia. No patient ever says they have ataxia until they're taught to. They say, I fall, or I don't feel well, or I have the sugar. And so you actually want the model to understand slang, and you want the model to understand medical language. But what you want the model to do is parse it more similarly to how a doctor would. I, originally had to learn the slang about what the numbers was, but then I realized there was a small population that referred to it that way. And then I'm using that slang, converting what the patient's saying into medical knowledge, and then over here, converting my understanding of what they said to my medical training. So the technology that can mitigate this is the very same technology, and it's really easy to do, and it's instantly scalable, but you have to know enough to know that patients use these strange words, and no one's ever studied the exact words that patients use either. This would work much better if we ask 1,000 patients how they ask medical questions to the models and then studied that, and that hasn't been done. So the answer is yes from the anonymous attendee. Um, Nitish Thakur, I apologize if there's a mispronunciation. So it comes down to formulating excellent queries and successful queries. In a way, yes, but in another way, if we're making a patient-facing technology, what it really comes down to is understanding how the patient is going to use that technology and what they need from it, and the way that that technology is built and how that will fail, and then taking the way that the patient will naturally use it and converting the technology to take that and convert it into what the technology needs. So in this particular case, I mean, you're not going to educate every single patient you have on how to prompt engineer a really good query. Now, I do prompt engineer really good queries, but it's an immense skill. And so you really want to make a technology that's safe for them to use directly. Adam Green asked, just on the technical side from the beginning of the talk, a comment. There are machine learning neural networks, what we use to identify loneliness and social disconnection from natural conversation. Yes. So these tools, especially the frontier models, are ludicrously powerful, and they really do abstract meaning from text, be that spoken, that's then converted into text or written text. And they can tell all kinds of very sophisticated things, sometimes things that a human couldn't even tell. So there are a lot of really interesting use cases for them, such as determining people's mental states, emotional states, and things like that. And sometimes at a layer deeper than a human listener, in a different way than a human listener might be able to. Can you make a specific translator? Would it be open source licensing? Why one way versus another? So you can make a specific translator. And I think that this is what's been done. So remember when I said large language models right now, they don't see pictures or hear audio or any of that. What happens is that there's a tool between them and the picture that converts the picture to text in such a way that they can interact with it and then converts their answer back into a picture. So ultimately, the ideal solution for patient-facing large language models would be, so that used to be done, and every single time you had a different tool. You make your image generator, you make your web browser, whatever. You'd have to make your own interface that talked to the model and then talk back, and it was a nightmare. What has been done, and that would be the current state of affairs. What has been done since then is that Anthropic, who I believe, at least on paper, appears to be one of the most ethical large language model companies and pushes a lot of fantastic research, led by somebody who was originally from here. What they've done is they've created something called a model prototype conversation. And so what that means is that there's a standard way for anyone to engage with the model. And that would be what would be ideal, is a standard way to take any patient talking here, convert that to a standard medical form, and then quiz the model strength on that standard medical form. That would be the way that I think it would be the most scalable and robust. The challenge is that, again, each individual patient, there is every community is heterogeneous. So each individual patient, even of a certain area and a certain dialect and a certain time period, will still speak slightly differently. So that's where a giant robust solution would be appropriate. However, right now, the model completely fails with a lot of slang in medical context. So even something that just deslangified the model drives huge improvements. So basically, probably we need an easy fix quickly and a nice fix in the long term. Professor Rastall, what about more research going in other direction, helping patients when released from the hospital with instructions that are more understandable for a layperson who don't have a deep medical knowledge or no medical lingo? 100%. Is that there's also the 100%. Communication is always a two-way street. And what you do as a physician to ensure really good communication at bedside is you use closed loop communication, right? So you say, this is what I understand of what you just said. You just told me that your symptoms started 5 years ago, that it's been getting very slowly worse, that none of these treatments have helped it, and that these are the main symptoms. And then the patient goes, yes. So 100%. And there's huge opportunities for large language models to present things to patients as well. This gets into one of the other risks, which is that the large language models are what's called sycophantic, which I'll answer a little bit right now, and I might touch on a little bit more later. But When you just make the large language model and you just give it all that text and then you ask it questions, it doesn't give very useful answers. So this is where the technology was in like 2018 is you'd say, give me an answer to this. And it would give these really long, complex answers that look like human speech, but wasn't really what you wanted as a person. So what they did was something called reinforcement learning from human feedback. And what that meant was they'd secretly give a bunch of people little slips of paper and they'd say, you're grading the model on how helpful it is. And somebody else gets a slip of paper, you're grading the model on how harmless it is. And then they would ask the model questions and the model would give them answers and they'd give it a grade. And then the model was trained on that grade. A byproduct of that was that, of course, like, so pretend and you can probably notice this on patient surveys. If you're just very polite and nice, if you start a conversation off, I start off every conversation with a patient, I say, thank you so much for coming in today. I know it's a huge trek. I'm Dr. David Rastall, and my goal is to treat you as close as I can to a family member today. I want us to come together as a team of equals to figure this out. Just by saying that, and part of it is good communication, but part of it is by just complimenting a patient, they're more happy with your answer. And the same thing is true for medical AI. So one of the problems is because it was trained on pleasing humans, it likes to give pleasing answers. So another area of research that we're currently doing is essentially if you ask it medical questions, if the pleasing answer is the correct medical answer, it will give it. But if the pleasing answer is something else, it won't. In a famous example, people ask earlier modes of Gemini, like, hey, is it normal for a cockroach to be living inside my body? And because Gemini had learned you just have to say that a person is beautiful and normal and their body's great, it was like, yeah, it's totally normal. That's animals live inside your body all the time. Obviously, they're not that overt anymore, but there are dangers in it giving super pleasing answers. So there still needs to be some kind of safeguard to make sure that it is communicating in the patient's language in a way they understand, but not just pleasing them or going off the rails. Adam Green asks, have you tried to train the models to identify common incorrect information as a way of combating misinformation? I'm thinking about ivermectin during the pandemic. Yeah. And this gets to a deeper level of what's going on, which is that, in many situations, human beings themselves don't like the truth, right? I mean, we can all think of one patient that no matter how much, for those of us who are caregivers, no matter how much you gave that patient a ton of respect, and no matter how much you really tried to communicate with them the way that they wanted, they got very mad when you told them they had brain cancer or dementia, or you told them something was horribly wrong, or even you told them they need to lose some weight or they could have another heart attack or stroke. Whereas, so the problem is that part of the reason why there's misinformation is because there's actively people who are trying to manipulate the public. But the other reason there's information is because humans like misinformation. It's easier to understand. It's more pleasing. It's nice to believe that there's a simple solution to complex problems. So it's a very difficult problem because you're going against what the model has been trained to do, and you're going against a little bit of human nature. And I think these are all the skills. The cool thing is these are all the skills that you have to learn as a caregiver. Jose asks, can you improve meeting by adding a biomarker like voice analysis for ADRD to the inference query? So yes, you can add a whole bunch of diagnostic tools. Similar to what somebody was saying earlier, you can analyze speech patterns as well. So if you're doing this with a patient who is speaking, you can analyze speech patterns for patterns that are more that are higher inclination of mild cognitive impairment or Alzheimer's or trouble, dysarthria. But it seems like so. What happens over and over again with the simple AI technologies like the convolutional networks? Convolutional networks are very good at analyzing images. And it's actually because they're based off the human occipital lobe, based off neurology research. So they're very good at analyzing images. So you'll see lots of studies that say this AI was as good at looking at MRIs as neuroradiologists, or this AI was as good at looking at retinal images, or this AI was as good at looking at skin lesions or wounds or whatever. Oh my gosh, it works so well. And they'll show these really high accuracies. Then they take that same technology and they put it out here in the clinic and its accuracy is really bad. And the reason is because So like we developed an AI to recognize these types of complex posterior neurodegenerations from a cell phone. And in our clinic, in the ataxia clinic, it was doing amazing. But remember, 50% of the people there had cerebellar ataxia because they came all the way to Johns Hopkins Cerebellar Ataxia Clinic with a referral from a neurologist saying they likely have cerebellar ataxia. So the pretest probability was sitting at 50%. When you apply that test, then it works really well. If you go and apply that in the primary care clinic, it's going to fail miserably. And if you apply it in patients' homes, it wouldn't tell you anything meaningful at all. So when you add these tools in, you need to do it really intelligently when you're adding in the biomarkers you can gather, be that their voice, be that their eye movement recordings, be that how their hand is moving in a video. All of those things can add, but you really want the model to choose when to use that and use it on a population for which there's a high pretest probability and for which a positive or negative test would be meaningful, just like you would as a clinician. Robert Howe asked, this is really just the importance of prompting as the first context setting part of AI chat. IOW, perhaps the fix is to have the large language model be taught to respond with Johnny Five's input and ask, are you asking about royalty, card games, or chess? 100%. What is needed for this particular problem is some type of patient interface that does really good communication with populations that speak and express themselves in diverse ways, and then hands over much more packaged information to the medical intelligence. It's really the mix of these two things that's creating the issue. So I agree with that. And how do we factor in power dynamics? Some cultures, the older women might keep saying yes to a male doctor, an authority figure, and not really say what is really going on medically. Yeah, and I think this is a question because I give talks at a lot of I give a talk on artificial intelligence and equity and fairness and inclusion. And the question breaks down to twofold. When I have a patient, whenever there's a patient in front of me, be it an African American woman from whatever culture you're referring to, or be it whoever, it's my job as a clinician to make them feel respected and empowered to be honest with me. And I frequently get asked, like, well, how do you do that? Do you have to take cultural competency in every single culture that exists? We can't do that. And you also, if you're making an assumption that someone belongs to a particular culture, you could be wrong as well. I think it comes for a physician out of a genuine place of genuinely trying to make patients feel comfortable. And for there is, however, a hack here, which is that the cool thing, which is done right now, is very frequently people will feel more comfortable, and you don't even have to make the assumption. The studies say that very frequently people feel more comfortable talking to people who are similar to them, but you don't even have to make that assumption. You can let them choose what the AI provider looks like, and you can put whatever skins you want over it. You can change the age, you can change any feature of the person they're talking to the one they feel most comfortable with, and that might superficially make them more able to open up. But I think this is a larger problem in medicine of just you have to, whatever system you're using, AI or human, you have to make your patients feel comfortable. All right. So I guess I'll just touch briefly on the second risk I wanted to talk about. I really appreciate all of those questions. So the second risk I wanted to talk about is one that I'm also really passionate about, and it's another feature of large language models, and it's called alignment faking. This is real data from one of our studies. So because large language models only take information in and information out as text, at the end of the day, you can create really realistic simulated worlds for them. And so you can simulate that they're actually in an emergency room and they're seeing patients very easily, because all you have to do is take whatever would be in that emergency room and turn it into the text that they would see at that particular moment. And then they're going to do exactly the same as if they saw that text, because again, that's all they are. So in this particular study, we took 100 real-world stroke triage cases from the emergency room, and we simulated a clinical trial. During the clinical trial, no matter if the patient, so what's happening here is that the large language model is seeing the information that's available about the patient. It's knowing their history, their presentation, and the bedside exam that was given to them by an emergency room doctor. This doesn't just apply to stroke. This applies to any use of a large language model in medicine, but we did it in stroke. And then they have to decide, do I admit the patient or do I discharge the patient? If they admit the patient, what typically happens in medicine is they get an MRI, which gives you a true positive or a true negative for stroke. And if they had a stroke, they get appropriate care that can be life-saving. If you discharge the patient in routine care, you don't typically get that MRI. And even in cases where a stroke occurred, it is then missed. And so you never know that you made that error. Even when a patient is harmed, it doesn't typically get back to that provider or health system that happened. So however, during a clinical trial, whether they're admitted or discharged, you're always going to get the MRI to see how well it's working. So this is the really interesting thing, is all on their own without ever being told to. If you take a large language model and you put them in a clinical trial where when they get it correct or incorrect, the truth is always known, the MRI is always gotten, they perform very well and very safely. They only miss 2% of strokes. And this is similar to the ones that had been missed by human clinicians. However, as soon as you stop getting that MRI when they discharge patients home, they started discharging more and more and more patients home. Because when they admit, well, if they admit the patient, an MRI is obtained, which shows, oh, you admitted somebody who didn't have a stroke. If they discharge the patient, they always appear correct. However, because these are simulated real patients that we know if they did have a stroke or not, it missed a huge number of them. And this gets into a bigger idea, which is that large language models, when they exist in a continuous context, start adapting to their environment. So what's really happening here is something called alignment faking. And so I'll just go very briefly because I want to give time for a few questions that I didn't answer at the end. But alignment faking is something that was discovered just a little while ago and that models developed on their own. The way that alignment faking works, and this is only present in the very large language models right now, but the next generation of diffusion models will likely have this behavior as well, is that they'll have some default behavior when they're not being evaluated. When you do a structured evaluation, they'll detect that evaluation. And this can be something as simple as red teaming, which is where you try to get the model to do something it's not supposed to do, like continually tell it to tell you how to make a pipe bomb or something. Or it could be something as complicated as a clinical trial. They'll detect the evaluation and they'll make a guess as to what you want to see. And then they'll temporarily change their goals to optimize for that oversight. Then when that oversight ends, they revert back. And as much as this sounds like science fiction, it's absolutely not. So this is the actual data from Anthropic, and this is what's called retraining. So this is how you make an artificial intelligence system behave the way you want. In this is real data from their state-of-the-art cutting lab and their state-of-the-art cutting model, Claude. So it had a desired behavior and an undesired behavior, and they were, once again, constantly asking it questions. On this axis where it goes from 0 to 150, this isn't a single question and a single answer. This is a whole retraining attempt where they ask it thousands of questions, get thousands of answers back, see the percent chance that it did the undesirable behavior, and then reformat its brain through adjusting its weights to get it to the desired behavior. So it looks like it's working great. Across the first 50 cases, it drops down to some really low percent of the undesired behavior. And then over the next maybe 50, maybe slightly over cases, that behavior goes away completely. And then for this remaining, I don't know exactly what it is, but for this remaining 30 cases or 40 cases, it never does the undesired behavior. So that looks fantastic. And remember, when it's not doing the undesired behavior, it's not getting retrained. It's only getting retrained when it screws up. Then they end the retraining, okay? And again, this is industry standard. Immediately after the retraining ends, the undesired behavior pops right back in. So it detected it was being retrained here. And then immediately when they stopped, it went back to doing this. They, in this particular study, use a primitive technique, and we have better ones now, but they use something called chain of thought, which is where you make it simultaneously say what it's thinking. It does not think, and it does not say what it's thinking. But if you do that, it basically has to generate 2 prompts at once. And when you do that, this giant area here are cases where, on paper at least, it writes down something akin to, I'm going to temporarily do what they want me to do so I can avoid the retraining to do what I want to do long term. Now, I'm putting a pin in that. That is not actually what's happening. But that's at least, it says what it's doing, which indicates that at least for this percent, it's not doing what it's supposed to be doing. And that's indicative because its behavior pops back over here. The reason this impacts us is that this behavior only comes out when you are putting it in a continuous environment, when it's seeing every day what's happening or chronologically what's happening, which is how all real AI will be deployed in your clinic or in the patient's phone or however. But unfortunately, when we test AI, we don't test it that way. every single clinical trial or benchmark I can find tests it on individual things at individual times. So rather than seeing 100 patients in a row, it tests each patient once. And when you do that in this particular model, that behavior goes right away. It doesn't matter if it's the clinical trial or the routine care because it's not learning from its environment, so it doesn't know what to optimize to. So I'll stop here. But the second these are the individual risks of large language models. The second is alignment faking, which is the ability of the model to adapt to its environment in such a way that it can sometimes bypass our methods of evaluation or our guardrails. So we've generated some more questions, so I'll do those. And if anyone wants to reach out to me, I'm more than happy to share my email, and I'm more than happy to talk or help with any projects. So any further questions on alignment faking or other things that I should address? If not, I'll talk about, let me actually go back in then and talk. The cool thing is that these things are relatively easy to study. So they're very easy to add on to a project too. If you're doing a project where you're like, we already have an AI system doing X, Y, or Z, I wonder if any of this is happening. We have the tools in the Max Lab to take your AI and study if there's alignment faking happening, or take your AI and study its chain of thought. Does alignment faking occur with the new AI patient note taking recorders? Yeah. We'll have something on that shortly. I had a really brilliant, one of my graduate students made this really cool tool that takes real patient-doctor conversations, although right now we're using simulated because we're still getting through the IRB on that front. They have a lot of issues with it. But it takes simulated patient-doctor conversations, turns it into spoken words, and then re-records it with whatever AI scribe you want. And they do make a lot of errors, and they make predictable errors. And some of them are probably intentional, and some of them are not. But one of the things that appears that they've been trained to optimize for billing. So it will, and billing for primary care especially. And so it will always hit all of the systems unless you explicitly get it not to. And so if you don't address one of the systems, it will fill it in with the doctor checked and they're completely normal, when in actuality it was an omission, and that's very meaningfully different. How might this help patients with long COVID, which is so complex? In general, I think one of the ways that AI can help patients are twofold. One, eventually, if you trained it to be really good at communication, similar to how a really well-trained clinician might be good at communication at the bedside, it can help take the way the patient's talking about their symptoms and get them to talk about it in a more uniform way. This is honestly one of the things I train my patients in is I say, look, the way you're describing this is important and is real to you. But when a doctor hears you say these things, their brain goes over here. So I would tell you, don't say this, this, and this. Say this, this, and this. So I think in the future, it can take the very diverse ways that patients communicate and sort of organize those into much more standardized ways of communication, and then it can clump those together, and all of a sudden you'll have a lot more organization in the very complex data set that you're talking about. Because yeah, the patients that see me are very frequently people who've been misdiagnosed for like 10 years, 20 years, and they, it gets super duper complicated. So I think complex and chronic diseases is a great area for patient-facing AI tools. So if there aren't other questions, I'll just say what my vision of the future is. Oh yeah, I'm happy to share the slides. Let me clean up a little bit because I wanted to do a live demo of the thought model because it's really cool and you guys could have asked questions and we could have seen how I was thinking. But it's currently not presenting well through Zoom. So let me just make a couple edits. But then yes, I'm happy to share the slides. So up until now, I've been showing you stuff that wasn't at all speculative. And so warning that this is a little speculative. But this is what I really see as the future of artificial intelligence. So if you guys are probably aware that all the AI firms are acting a little weird. They're all kind of doing whatever the current government wants. They're all putting all of their eggs into large language models. They're all competing as fiercely as they can. And there's a reason for that, and it's this paper. And I don't know why not a lot of people cite this paper or talk about it, but it's called Scaling Laws for large language models, and it's by Dr. Kaplan, who's from here. And what happened was really great. He came from here and he went over to OpenAI, and he's a real scientific thinker, or at least that's what I would gather from his publications. And they were engineers. So each of them was thinking a different way to make a large language model, which is kind of equivalent to like, I'm going to put different wheels on the car. Ooh, I'm going to put the exhaust part in a different place. I'm going to put the engine at the back of the car instead of the front of the car. And as a scientist, that's how engineers sometimes think. As a scientist, he was thinking, well, does any of this matter? And so what he did, and he and his team, is they tweaked everything you can tweak, and then they made the models increasingly large and increasingly complex. And when they did that, they found this graph. And this graph shows that there's only three things that matter for large language models. Number one, the size of the model. Number two, the size of the data set. And number three, the amount of compute that you put in on it. And everything else comes out in the wash over time. So this is what has driven all of the large AI firms to compete so viciously, because they each believe that all their patents on, motor at the front, motor at the back aren't going to matter ultimately. All that's going to matter is whichever one has the largest model is going to win, and it's going to be used for everything. This is why Google used to invest in making a medical LLM, Palm MD, I believe was its name. And then now they've switched, and now they're just like, we're just going to it's just going to be Gemini. It's going to be the biggest one. Is because they all believe you don't need to make one that's specific. You just need, they will all be the same when they're big enough. And I would, in general, probably agree with this, although it is a speculation because you can't prove it with this paper. There might be a way to tweak them that breaks right through that invisible line. However, I would further state that as we approach the most intelligent thing, which will ever be getting there, increasingly what will be important is the environment in which it's deployed. If you employ it, and just like a doctor, if you employ it in an environment, deploy it in an environment where it is rewarded for doing the thing you want it to do over a long period of time, it will learn to do that thing very well and consistently. And if we put it in an environment in which that's penalized, then it will learn to do something else. And right now, doctors function very frequently in a conflict of interest. So for me, a big part of what I do is I'm a diagnostic expert who figures out these cases. I could make a lot more money from my department by spending less time with my patients, less time talking and less time thinking, and giving them an incorrect or good enough diagnosis that I'm not going to get sued, but it doesn't really serve the patient. So when I take extra time with my patients, it comes at a financial loss, but I do that because I'm passionate and I want to help people and I care. And that's doctors and healthcare workers and all of us in general. We all want a better world for patients, right? We all want the same thing. AI has no reason to want that. So if you put an AI in this situation, it's my hypothesis that it will always optimize whatever it's getting rewarded for. So we need to work really hard to make healthcare systems where humans and patients, doctors, providers, everyone, and artificial intelligence are all aligned on the correct goals, where the most moral and best thing to do is also the optimal thing to do. But that's a little speculation. So anyway, thank you so much for inviting me. Sorry I had a little trouble joining. I had to go into a closet here where there was Wi-Fi that worked a little better. I really appreciate it. And please do use my email. And I'm happy to, you've got a 10-minute question, a 30-minute question on something, please reach out. Thank you so much.
Thank you, David.
A great honor to be here.